webinar. And before I introduce this specific webinar and hand over to Jan, I also wanted to remind you that, first of all, if you're not already an AFINet member, you should become so. And we have just had a relaunch of our website. Many thanks to Jill Velleman, where you can find many materials also on the 5-step method, which will be the topic today. So and of course, also this webinar is part of a series of webinars which are taking place on a monthly basis. And we had many interesting talks so far, and we will continue for, I don't know how long, at least I think for the rest of the year, we already have webinars in plan. But regarding today's issue, I would warmly like to welcome Jan Larkin. The presentation, as you might have seen in the announcement, initially was planned to be held by Jan and Lorna Templeton, who unfortunately cannot be with us today due to a family bereavement. But I'm really happy to introduce Jan for today, and I received a brief CV of her, and I thought it's so much experience that I just wanted to pick out a few small items. Jan was trained as a registered mental nurse in the 80s and started working with older adults, and then was trained as a clinical psychologist in Edinburgh, and quite soon moved into the addiction treatment system. And in the early 2000s, the interest in working with family members did start when she started to work with Lorna Templeton and Richard Velleman. And already back to this date, the introduction of the 5-step approach to services started. And so there's a long experience of implementing family-based practice, which will be the topic of the talk today. Besides this, there has also been, Jan has been involved in the development of several alcohol guidelines. So what you're gonna here today will be a lot of, practical experience in working with family members and implementing these services. And the talk will be about 45 minutes, and afterwards we'll have about 45 minutes time for discussion. The whole session will be recorded, and for all of your colleagues who are not able to join us today, there'll be the opportunity to watch it on YouTube or on the AFINet website. And so I'll hand over to you, Jan, and I'm very interested to hear about your experiences and strategies in implementing the 5-step method. Thank you very much.
Thanks very much, Gallus. Yeah, I'm sorry that Lorna can't be here. I just wanted to say sort of thanks to Lorna for all the work that we've been doing together in terms of training on the 5-step approach over the last 10 years, and I'll kind of be touching on that through the presentation. So as suggested, this is about introducing and embedding the 5-step method across our organisation, which is called Turning Point. And the subject of this really is about a kind of reflection, looking back over the last 11 years of working with the 5-step method in Turning Point. And I guess the objective really is to look at what's helped to embed the 5-step method, what some of the challenges have been, and how we've attempted to overcome them. So it's very much a kind of reflective look at the implementation of 5-step rather than a kind of research-based presentation. So bear with me on that. Can we go on to the next slide, please? So just going to talk about a brief introduction to Turning Point, so who we are, what we do. really brief description of the 5-step intervention, as I'm aware that most of you would be very familiar with it. Some context for how we introduced 5-step into Turning Point. So how did it begin? And then a little bit of chronology about what's happened over those years since 2010 in terms of the implementation. As I said, what's been quite challenging and some of the ways that we've tried to address those challenges. Some recent developments and some of the progress in those developments, where we are now, and then some future plans. So we can go on to the next slide, please. Thanks. So Turning Point it's a non-statutory health and social care provider, which emerged from Centrepoint, which was a social initiative for homeless people in London in the 1960s. So Turning Point's been going for quite a long time. So we are commissioned generally in different areas to provide treatment or support for people with substance use, for people with mental health difficulties, and for people with intellectual disabilities, mainly living in their own homes. So we cover working with people in all those areas and also in public health. The work I'm going to talk about today is mainly in the substance misuse field, although I will go on to talk a little more about some of the work we're starting to do with 5-step in the mental health sphere. And quite a big organisation. We're across England only, but we employ probably, I think, between 4,000 and 5,000 staff across those services. Probably quite important to say that those services are separate services, which is quite interesting in the sense that we're not yet into the realms of co-commissioning, unfortunately. So mental health services are commissioned separately from substance misuse and from intellectual disabilities, although we're trying to work towards doing some more work together, because clearly when we're working with people, they don't fit sort of neatly into different categories. So can we go on to the next slide, please? Talk a little bit about how this all fits together. So in 2008, Turning Point developed its first integrated drug and alcohol service. So up to that, we'd had various separate services looking at providing support for people with substance misuse issues. But when I say non-integrated, they were separate, smaller services. So integrated services are big kind of county-wide services that support people with both drug and alcohol problems, often with young people services attached to them. So an integrated service is generally a kind of county-wide, much bigger service. So our first integrated service was in Somerset in 2008. And now there are 12 integrated drug and alcohol services across England, generally across counties or across parts of counties. So quite big services. We also have a prison substance misuse service in Thameside in London, a detox unit in Manchester, and 2 residential rehab units in Oldham and Cumbria. And I guess we've done less in terms of 5-step in those services, but we've done some, certainly with the rehabs. And the idea of kind of the staffing in the service has kind of evolved so that each integrated service has a clinical team. So usually there'll be a clinical lead who's often a consultant psychiatrist or a GP with special interest. We'll have nurses. We have recovery workers, lots of peer mentors, and we will also have a clinical counselling or forensic psychologist and some specialist psychosocial intervention group leads. And I guess I put that in because when we're talking about embedding the 5-step method, it's been really important to have those people in the services to drive and help implement 5-step beyond the training. And I think that's something we've kind of learnt over time, that where we can get those people or staffing structures embedded, it's been easier to embed 5-step also. So we can just go on to the next slide, please. Thanks. So I'm just, as I said, briefly going to talk about the 5-step intervention. As I'm sure most of us will be have been working with it for many years, will be very aware of it. So we know that it was originally developed for families affected by a loved one's problem, alcohol or drug use, that it's a brief structured psychosocial intervention, that it's for family members in their own right, regardless of the circumstances of the substance user. And I guess on this point, it's taken quite a long time in services to get to the point where staff and clients understand that the fact that 5-step is for family members in their own right. And there are still, 10 years down the line, we still have conversations about, is this about family members bringing their loved ones into treatment? What's the difference between 5-step and network therapies, for example. So it's interesting how often the family approaches still get quite intertwined, kind of even quite a long time after starting to embed them. We know that the evidence was based in two ways, based in two main ways. So developed from research about how families are affected by a loved one's substance misuse, and we know there's been a lot of international research in that regard, and evaluating the impact of the 5-step method intervention that we've developed. And I'm going to talk a little bit more about the evaluation side as one of the challenges that we've had in Turning Point. So if we can go on to the next slide, please. So who developed the 5-step method? So Now Addiction in the Family International Network, particularly Jim Alford, Richard Velleman, Alex Capello, Lorna Templeton and Jill Velleman. And I know lots of other people have been involved along the way. We know that there's quite an amount of international work that's gone on, and great to see that there are kind of lots of 5-step colleagues around the world, which I've heard kind of little bits and pieces about, which has been really interesting. So we can go on to the next slide, please. I think having done quite a lot of 5-step training with Lorna Templeton, something that's stood out has been how quickly practitioners pick up the model behind 5-step, and I think that's been kind of quite refreshing, that it's actually something that's actually quite easy to get across to people, and that has a lot of face validity when people are working with people with substance use. So the idea that families experience stress as a result of somebody's health problem or disability or substance use, that the strain of dealing with these situations can lead to ill health and other negative impacts, and that the strain can be influenced and mediated by information and understanding, ways of coping, and amount and quality of social support. So again, I think the fact that the model came from talking to lots of family members across the world tends to be really well received in training. I think it doesn't come that people perceive it as not something that kind of comes from a book or a text, or an academic kind of resource. It developed into one, but the idea that it came from actually speaking to family members about their experiences, I think really helps to get across the idea of 5-step to practitioners and to family members. And so the next slide is just literally skipping through a kind of summary of the 5 steps themselves. So we can go on to the next slide, please. So step 1, listening and exploring concerns. And certainly in terms of the training, we do quite a lot of work about the crossover between motivational interviewing all the way through the intervention, and particularly in step 1. So looking at those key skills of open-ended listening, affirmation, reflective listening, and open-ended questions, affirmation, reflective listening, and summarizing. Step 2, providing relevant, specific, and targeted information. And it's interesting, this is one in terms of training and implementation that it's sometimes quite hard to get over, which I find interesting because it's quite straightforward, the idea of providing information. I think what we need to really, what we struggle a little bit with is that the practitioner is asking the family member what they need to know before they provide the information, rather than going in and kind of giving a spiel or a kind of set script about relapse or drug treatment or the substances themselves. So interesting, I find that step 2, whilst it looks fairly straightforward, can be quite hard to get across, as in we need to use the kind of motivational interviewing model of elicit, provide elicit, so find out what the person needs to know, then provide some information, and then find out where it leaves them, rather than going in with a kind of set piece. Step 3 is exploring coping responses, as we know. Step 4, exploring and enhancing support, and step 5, discussing and exploring further needs. So can we go to the next slide? I kind of want to get into the kind of the story of the implementation, really. So that's great. So the journey of 5 steps so far. So if we go on to the next one, that'd be great. I thought I'd just explain a bit about context. So kind of how did 5-step get into Turning Point in the first place? So I had been working in a substance misuse NHS service in Wiltshire for 7 years before I joined Turning Point in 2010. And I was kind of fortunate really to be working in a team where we were approached by Lorna Templeton and Richard Velleman about doing some action research about how we could make that drug and alcohol team more family focused. And so we spent some time looking at how could we encourage working with family members in all kinds of ways. So how could we encourage family members to come along to assessments with clients where the clients were put up for them doing that? How could we involve family members more in the client's treatment, but also how could we look at supporting family members in their own right? So we spent a few years in that service with Lorna and Richard looking at how we might do that. And that was a really interesting experience. Over that period also, so I'm a self-trained in use of the five-step approach. We started working with five-step with family members, and also contributed to the training DVD, the filming on the training DVD that was going on at that time. In terms of implementation, it was really helpful to have Richard and Lorna coming into the service periodically to talk to us about what was going on and what was working or not working about becoming more family focused. It took us a little while to get our heads around it as a team, I think, but once we did, it became kind of really helpful. The tricky bit was when the research team were no longer there, actually keeping that going. And I think there were lots of reasons for that, as there are in most organisations, that there were always challenges for prioritisation, that it was really hard to keep the kind of the focus on family members sort of high profile enough to be able to maintain some of the gains that we'd made during the research period. And also there was lots of bureaucracy. So for example, we talked about how might we record working with family members in their own right, separately obviously from the person using substances. So there were things about recording, how might we actually be able to record so that family members were treated as clients of the service rather than, attached to the service user's record, so to speak. So there were lots of kind of difficulties in terms of working with kind of big systems that don't change very quickly, whilst there are lots of other priorities going on. So I think we came a certain way in terms of becoming more family focused, but my experience was that some of those ways that we had changed the team working fell away a little bit when we didn't have the kind of the research team coming in and keeping it really high profile. So it was interesting in terms of looking at how that works in practice. So if we can go on to the next slide, then. So that was where I was coming from when I moved into Turning Point. So at the time, in 2010, it wasn't that usual to have clinical psychology in a non-statutory substance misuse service. Most clinical psychologists at that time were in National Health services. So actually, it was really good because I was able to sort of go into a non-statutory service and have a bit of flexibility and try and sort of develop the role rather than sort of going into a role that somebody else had already created. The remit was to assess all the psychosocial interventions that we offered across the board. So that'd be working with alcohol and drug users in different settings at different stages of recovery and change, in accordance with national guidance. So there was a big emphasis on making sure that we were doing things that was consistent with NICE, with what was then the National Treatment Agency and Department of Health. And so the remit was to develop a model of psychosocial interventions for all types of clients in the form of manualised interventions. Lots of pros and cons in terms of manualised interventions, but I think what we've found over time is they're possibly the best way of making sure that we've got evidence-based elements in treatment with recovery workers and service users, so that there's a standardized approach and we kind of know what we're delivering, and we can get some sort of treatment fidelity by offering supervision to those manualised interventions. And a remit was also to train and supervise staff and to lead on service evaluation. So that was the picture in 2010 in terms of the psychology role. And we've done lots of that over the years. We've developed psychosocial interventions based on lots of different approaches. We started off mainly with CBT. We now use quite a lot of third wave approaches, so mindfulness-based relapse prevention, etc. So all of that work's been going alongside the five-step approach. So if we go on to the next slide, please. I kind of, it probably looks a bit ridiculous looking back, but at the moment, I kind of felt like it was a bit of a light bulb moment where I felt like I'd been really struggling to maintain some of the gains that we've made in terms of working with family members in the NHS service. And it kind of seemed to be a really opportune moment to think, right, we're developing a model of psychosocial interventions for all the people that we work with. So it seemed a really opportune moment to think, right, let's incorporate the 5-step intervention into the core treatment offer. And to challenge some of the assumptions that I'm sure we've all worked with over the years, that supporting affected others or concerned others or family members is an add-on. So if there's time and there's extra money, which we know there never is, we'll put in some of these sort of souped up family member interventions. And actually what happens is it never happens because it's not part of the core offer. So there was also an appetite, I think, at that time in Somerset to work with family members. So there were quite a few people in those services who had worked with family members for a very long time. They were kind of experienced recovery workers. They hadn't worked with a 5-step approach. They'd worked with family members in lots of other ways, but there was quite an appetite to really think about offering a high quality intervention with family members, and then to be able to assess whether that was helpful or not. So what we started to do was to identify key members of staff who were motivated to train in and join 5-step supervision. So we did that across 4 teams in Somerset. And also we were thinking about whether we wanted to offer 5-step individually or in a group context. For many reasons. One, because there were already carer support groups, so people were used to family members coming together and supporting each other. And also because our interventions for service users were mainly group-based. We started to look at, could we sort of develop some guidance around the 5 steps that would enable them to be facilitated in a group context. And, I must say, I think coming from the NHS into the 3rd sector, I had quite, I think I had some prejudices about group work. And I think when I came into a 3rd sector organisation, I believed that probably individual work was kind of gold standard, and group work was something that you did if you possibly had less resources and you had to spread things a bit more thinly and you had to see lots of people at the same time because you couldn't offer individual. That was the kind of viewpoint I was coming from, really. And I think, 11 years in, I'm really convinced about, and I'm sure lots of people are convinced about the power of group work. And I think from the start, in the 5-step intervention, the group work seemed to work really well. Not for everybody. I think we're going to go on to that in terms of flexibility of approach. I'm not suggesting that everybody that can benefit from a group or even wants to attend a group, but actually it fit really well with the system that we had at the time. And so we started to develop some guidance about how are you going to facilitate each of those steps in a group context. So we started off in Turning Point offering 5-step only in a group context. If we can go on to the next slide, please. Some of the lessons learned, and I suppose some of these are probably fairly obvious, but it was crucial for group facilitators to be given time to become familiar with the materials and the approach. We very quickly found that a kind of, even 1 or 2 days of training, as we all know, you get that training effect where people are very motivated and kind of excited, and then 2 weeks later, it's very hard to remember what was in the training. So if we didn't provide dedicated time for people to get familiar with some of the materials, I mean, there's a lot in the 5-step intervention, as we know, which can't all be covered on a training day. We found that was kind of crucial. And also, we really wanted to be able to offer the 5-step approach as an individual intervention also. That was quite difficult at that time because we didn't have dedicated family worker posts. So we had recovery workers, often with lots of people on their caseloads, and then we had to try and find some time for them to be able to not only look at the materials and get familiar with them, but then also offer 5-step on a one-to-one basis. That was quite difficult to do. Also because Somerset's quite a rural county, and there was a whole logistics about people getting into different offices and places, community venues, to get that support. We also did some work with the family members to say, to ask them what they thought about the 5-step intervention. And what we found was we tried to run it in various ways, and we found that it worked best where we could offer a 5-step over 5 weeks, a 5-step group over 5 weeks. And then people would sign up for that group. They would have the 5-week intervention, and then they could go back and maybe do some more unstructured carer support work. They definitely wanted the 5 steps weekly or 2 weekly, but no less frequently, because people found it really hard to keep the train of what they were doing. They also wanted both. So family members were saying we like the 5-step, we quite like the structured aspect to it. We like the workbooks. We also want an ongoing carer support group that we can dip in and out of, and that is unstructured, that we can just go in and have a cup of tea and talk to people. So they kind of wanted both options, which is kind of what we offer to people with substance use issues. So, you know, we should be offering a range of interventions for family members, I believe. So also, although we were using outcome measures and still do for all of our core interventions with service users using substances, it has been incredibly difficult to embed the family member questionnaire pre and post the intervention because of, you know, for lots of reasons, really. And because also a lot of staff that come in from other organisations are not used to using outcome measures. You know, they're very often, you know, they're always used, aren't they, in research contexts, but in service contexts, lots of people come from other organisations wouldn't, you know, they're just not used to using them. And so to remember to do a questionnaire is something quite alien to lots of recovery workers. Also, the even bigger problem has been dedicated time and input for data collection and analysis. So if you've got all of these questionnaires from family members, you've then got to have a system and time to be able to collate the data, analyze it, and then disseminate it. And that's always been an issue in terms of having the capacity to be able to do that. We don't have a dedicated research post or data post, so that's been quite difficult. We go on to the next slide, please. So the kind of the middle years between 2012 and 2018. So we had a big expansion in the number of services that we were offering. So we've gone from 1 to 12 across England, and there's been variations in that across the years. And obviously we've had changes in commissioning structures. Thankfully, we're now being commissioned for longer periods of time. At one point, we were being commissioned for 3-year periods of time, which is really challenging when you go into a service that's had a different provider. They've had different sort of family work. They've had, you know, either had family work systems or not. You know, developing the enthusiasm for 5-step, doing the training, doing the supervision. You know, you get into the way of it, and then, you know, you're thinking about recommissioning again. So that's just those 3-year commissioning cycles are really difficult to keep things going in. Now commissioning is usually sort of 5 or 7 years, which is a lot better. We've also had obviously government priorities shifting from harm reduction right into the recovery agenda. So the pendulum swung from one side to the other, whereby before it was very much about engaging people in treatment and keeping people in treatment. And now the focus is on people moving out of treatment and coming off opiate substitution. And that obviously has had an impact on family members. As I said earlier on, we've had an expansion of the practitioner psychologist provision in Turning Point. So now most of the integrated services would have a psychologist or a master CBT therapist to lead the psychosocial interventions, which includes the 5-step approach. So if we go on to the next slide, please. Thanks. I think for me, in terms of service provision, the most important part actually has been working with the bid teams to get 5-step and carer support into bids for new contracts. So in terms of commissioning, you know, we have these commissioning cycles, and we may go in and provide a treatment service for 5 years, and then the service comes up for recommissioning, and there is a competitive bid process where different organisations will bid to provide that service for the next 5 or 7 years. If you don't get an intervention in at that stage when you're bidding for that contract, it's very hard to then get it off the ground because there are so many other priorities. So over those years, I think what we learned as a team was we needed to get in at the bid stage. So if we were thinking about going, for example, a service in Leicestershire, we would work with the people who write that bid to say, where's the family member provision? Not only where is it, what is it? We need to put 5-step in the bid, not just family member provision. So I think we've got better over the years at being a little bit more assertive in making sure not only that we are saying we're going to do family member support, but that we're going to have a different types. We're going to have unstructured support, we're going to have 5-step, etc., and sometimes other network therapies. Because the good thing is then if it's in the bid, you know, we're in that contract, and then 2 years down the line, the commissioner can turn around and say, well, where's the family member provision? Where's the 5-step? You know, so we've committed to it, and we've got to do it. So I think that's been the biggest lesson really that we've learned. Also, probably equally as important has been a change in staffing structures. So as we've developed different services across different areas, we've introduced specialist roles. And this is interesting because it feels like the pendulum's swung back to how things were, you know, a few years ago in substance misuse services. A few years ago in substance misuse services, you know, we used to have separate alcohol teams and separate drug teams and separate alcohol workers and, you know, separate people looking at rehab provision. And I think then we went very generalist where all the staff have to do everything, which I don't think ever works. And then we're moving a little bit more back towards specialist roles again. So we started to develop family worker posts, which I'm really thrilled about. And we don't have family worker posts in all the services by any means, but we have quite a few family worker posts. And then we really saw an improvement in 5-step provision, because not only could we offer group provision, we could also offer individual 5-step. It's only through having family worker posts that we've been able to offer individual 5-step support. And we've also moved towards those family workers being supervised by psychologists or master CBT therapists, because again, I think because the family members can so often slip down the agenda, as we're all very familiar with, for me, it's been really important to put that dedicated supervision in, which is separate from the recovery workers or the family workers line management. So it's a separate supervision that is dedicated purely to psychosocial interventions with family members. It doesn't deal with kind of numbers on caseload or all the kind of management stuff. It's very much about what is it we're doing with people and how can we improve the quality of that. The other thing that we've done over the past couple of years, introduce family worker forums. So we've got a national family worker forum, which meets regularly, and which actually is really, really easy to do now that we're doing much more remote working, where we look at good practice, we look at what we're doing with family members, we look at assessment procedures, we look at referrals, we look at interventions themselves, and there's lots of stuff going on. So we've got 5-step structured, we've got unstructured carer support groups, and then also lots of activity groups going on in terms of things like mindful walking and other kind of not talking therapy groups. So I shall speed up now. So we'll talk about, if we can go on to the next slide, please. We're just going to talk about recent developments and adaptations. Thank you. So we got that far. So we had a number of services. We were offering 5-step to as many family members as we could engage in treatment. And then I think over the past couple of years, been much more about widening that offer. So out of services where we already know family members are engaging, into how can we engage more family members? So we have a team called Contact Point, which is a central assessment point for 5 substance misuse services. So they're the front end people that take calls from people in those services, so people using substances, people wanting to engage in treatment, and also lots of the time from family members who will then phone in Contact Point and say, look, my son is, he's drinking heavily. We live in the, in the Suffolk area. I'm really trying to get him into treatment. So what we started to do was to work with the Contact Point team to enable them to send out the self-help book. We didn't have the capacity for them to actually start to do 5-step intervention. That wasn't really what they were there for, but we did get them to send out the 5-step self-help handbook, printed or PDF, and also signpost into services and say that there is a family support service in your area. We've had lots of requests for translated versions of handbooks, and I'm sure is the case across lots of different countries, particularly Polish. So we're and particularly from the Contact Point, we get lots of people from lots of different nationalities phoning in. So that's something that we need to look at in terms of not excluding people. And I think it's something we probably need to talk more about, and would be interesting actually to talk about in the discussion if we have some time to do that. So if we go to the next slide, please. The other thing we've thought about is adapting 5-step for other family members. So this came from Turning Point developed the carers service. It's purely a service for carers, family members in Hertfordshire. So working with family members of people affected by mental health and sensory difficulties, dementia, intellectual disabilities, and substance misuse. So with the permission of AFINet, we worked with Lorna Templeton and other colleagues in Turning Point to adapt 5-step handbooks to add in some specific appendices with information about conditions and support resources. So using those 5 steps as we would in substance misuse, but having relevant information as an appendices for each of those conditions. And so myself and Lorna have trained the team and starting to implement it. Again, there's been challenges in the sense that the team is actually commissioned to work with not only the carers of people with those difficulties, but also with the people with difficulties themselves. And what the team say is actually when they're working with somebody, and predominantly they're working with people who are carers of people with dementia, they're saying actually what the carers mainly want is for us to sit with that person with dementia while the carer goes and does something that they want to go and do. So they kind of want to break more than to be, you know, to have the kind of talking therapy side of it. So we're kind of trying to work on that structure a little bit to be able to add in, for example, extra phone support so that the practitioner can phone the carer at another time. They've had the break, so at a different time to do some 5 steps. So we're kind of still working on that. It's quite a tricky service to implement a 5-step into, but we're still working with it. If you can go on to the next slide, please. Very pleased to have worked with Richard and Jill Velleman mainly on the, and Lorna on the My Turning Point digital platform, so the digital version of 5-step. Developed over the last couple of years, and we've begun a pilot of the intervention last year. So this is an online version of the 5-step approach, which the person can do on their own at home, and they will have 3 guidance phone calls from the practitioner, one at the beginning, one in the middle, and one at the end. The practitioner can also see the content that they put onto the platform, so it's interactive in that sense, although it's not live. We've currently got 24 family members in that intervention, and they're being supported through the intervention by people who've been trained and are supervised, including family workers, assistant psychologists, and a couple of the contact point staff, interestingly, who became very interested in offering the intervention when they'd had quite a few phone calls from family members. We're still in the phase of actually completing the pilot and writing it up. The initial feedback is promising. The disengagement data is really similar to other online interventions. There's a kind of tendency in online interventions for people to drop out after session 2, and that's true across lots of digital interventions, and we're getting the same thing in 5 steps, so we need to look at that again. But what we're also finding is that in certain places where they're doing the pilot, shorter, more frequent phone calls seem to be working better. So rather than phoning the family member at the beginning of the intervention, you know, for 40 minutes, in the middle of 40 minutes, at the end 40 minutes, actually phoning on a weekly basis for even 10, 15 minutes seems to be helping to engage people, which is kind of what you would expect, but that's been quite interesting. The other interesting feedback, we've had 5 exit interviews with people that have completed the 5-step online. And the other interesting thing that's coming through is people are kind of, of those 5 people, talking about the coping step 3 and kind of wanting more guidance on how to cope. And that's an interesting one, isn't it? Because obviously in 5-step, we're talking about the pros and cons of different coping dilemmas. We're not kind of giving guidance about how to do that. And we're just wondering how that's translated onto the digital platform, and whether it's because people aren't having conversations with practitioners that they're perceiving that step a little bit differently. So, you know, we've only got 5 exit interviews so far. So we'll kind of hopefully get some more information on that as time goes on. And if we can go to the next slide, please. Thanks. The other thing that I'm really pleased about actually is that we're now developing family peer mentors. This is just this year. So in Turning Point, we work quite closely with people with lived experience. So we have peer mentors involved in engagement of service users and delivery and co-facilitating groups and doing lots of things to help people to engage. And, you know, the power of kind of observing, you know, people with lived experience in recovery is kind of something that's probably is more important than any, you know, any structure of a psychosocial intervention that we would offer. And we've had quite a few family members across the years being, you know, expressed interest in being peer mentors, but we've never kind of got to the point where we've been able to develop a role that is specifically about being a family peer mentor rather than a generic peer mentor. But this year, we've started to work with the peer leads, the national peer leads, in development of a family peer mentor training, which includes 5-step, which will then enable those family peer mentors to co-facilitate 5-step groups. So those will be people who don't necessarily have lived experience of substance misuse themselves, but always have lived experience of being a family member of somebody with substance misuse issues. And so that kind of seems to be a real step forward. So what we're hoping is all of our 5-step groups will be facilitated by a family worker and then co-facilitated by a family peer mentor. And we believe that's going to make it a kind of a richer experience for family members in the group. So just almost coming to the end now. So we can go on to the next slide. I'm just going to talk a little bit about where we are now. And the next one, please. So we've got regular 5-step groups and carer support groups in 8 of our integrated substance misuse services. During the pandemic, we use WebEx, which is a sort of Zoom type platform. So we've offered groups on WebEx, and we're soon to get the face-to-face groups back. What we're going to move into is to have a blended approach where we can offer individual sessions on the phone, individual sessions on WebEx, group sessions on WebEx, and face-to-face group sessions, so that people have got a range of options that they can opt into. 2 of the services we don't currently have 5-step running for various reasons, and 2 of the services we work alongside carers organisations, and they're commissioned to provide that family member support. So we work with them, but they would often be using different approaches. We have 14 dedicated family workers across 8 services, which I think that's been quite an exciting development from my perspective. So that it's becoming more usual now when we're bidding for contracts to have a family worker in the staffing structure. And for example, one area in Somerset, we've got 4 family workers in one service, so it's great. So for example, in Somerset, I think we're supporting 100 family members at the moment across those 4 family workers. So, if we could have more of those, that would be great. We've also got 2 accredited 5-step practitioners, and where we have family workers, they're also offering individual 5-step. We've got 6 workers trained and supervised in digital 5-step as a pilot, and then we're going to be hopefully moving that into the wider services. So we continue to offer 5-step training. So I usually do the 5-step training with Lorna Templeton, and we offer that generally about 3 times a year across different services. We have been doing that online. I think there are pros and cons to that. We find doing the skills practice online quite difficult because we need quite a few facilitators to be able to observe people's skills practice, which is much easier to observe in a face-to-face context, I think. We've got regular 5-step supervision, which, as I said, was offered by the psychologists and PSI leads everywhere that we offer 5-step. And it is now a core intervention, I think, finally. It feels like it's been quite a long time coming, but it is a core intervention included in all new services. So now you don't even have to go to the bid team and say, oh, don't forget, we need to put 5-step in there and have a family member intervention. It's already there. So that's fantastic. I'm not suggesting that everything's kind of perfect, but things have improved quite a bit. The next couple of slides are some data. As I said before, we've had great difficulty in actually getting family member questionnaires in, but scores are kind of basically going in the right direction. I'm not going to linger on these because I just want to get onto the last part, which is about where we're going to go next. But essentially, these are from 48 family members, and if you think about how many family member groups we've got going on, we've got very little data because of the difficulties that we've been experiencing. We've actually got lots of data out there. It's about getting the time to get it, to collate it and to analyze it. So this is kind of a fraction of what we've actually got. So we can just go on to the next slide, please. Again, that's total family burden. So we know again that scores are going in the right direction based on these 48 people. As I said, lots more data to collate and to analyze, and hopefully we'll get to be able to do that. If we look into future plans, onto the next slide. Thank you. Data collection and evaluation, just what I'm saying. Huge geographical area, resources are limited. Now, happily, we have an online version of the family member questionnaire, which was developed for the digital platform. And now, for online groups, that gets automatically sent out to family members. They can complete it online, and then the data comes into a kind of central repository. So that will be absolutely fantastic in terms of getting data collated automatically. We're also doing much better in terms of online groups at getting session by session feedback from family members. So every couple of weeks we will get a a report generated that gives us feedback for every single group, both kind of scores in terms of how helpful it was and open-ended evaluation. So I'm hoping that kind of this time next year will be much better in terms of data collection and analysis than we are now. If you just go on to the next slide, it's just about communication. I'm almost finished. One of the London services is actually very good at sharing detailed information on family work with commissioners. I don't think it's something that we're particularly great at. I think often it's because commissioners don't necessarily ask about family member work. And often we're concentrating on the key performance indicators, whereas if commissioners asked us more about it and we had to report more, I think that would be a helpful situation. But we're working with that London team to see how we can share things with commissioners that we're currently doing. I'm working on the Public Health England Alcohol Guidelines group. So there's alcohol guidelines coming out soon, and made sure that the family member interventions are included as a core intervention within that chapter. And also, there's a lot of criminal justice funding at the moment, as people may know about, fixed term funding for criminal justice work, which we're also trying to include family members into family work into. So where we've got extra funding in an area, for example, Wakefield, we're thinking, right, we've got this extra money for a year, let's get some family worker posts in. And make sure that we're not only offering interventions to people with offending behaviours, but also to their families. So that's something that's what we're doing now. And finally, I think the next slide is about digital 5-step. We've got the pilot findings to be analysed in the next couple of months. We're learning from the pilot in terms of how much guidance do people need. Can we engage people earlier? Because we're wondering about how people get referred into the digital 5-step, and whether actually if we can when we get digital 5-step out beyond the pilot project, we could actually put links onto Turning Point websites and get people in earlier and see whether there's any different evaluation from that. And obviously we're hoping to make digital 5-step available nationally when we've completed the pilot in the next month or two. And almost finally, I keep saying almost finally, but I believe this is the penultimate slide. If we've gone to the next one, adapted 5-step for mental health settings. So we talked about that adapted version that we are offering in the Hertfordshire Carers Service. We're also talking about piloting that adapted version in the Leicester Young People's Crisis Service with affected parents. So young people coming into the crisis cafe, often with their parents. Could we offer the parents some support? We're also thinking about, and we're going to talk to AFINet about piloting it in our Nottingham Connect service, which is hopefully to have a new family worker post for working with family members of people with, in inverted commas, personality disorders. And we're going to be inviting mental health family workers to Substance Misuse Family Workers Forum. So we're going to try and do some mental health substance misuse crossover work. So we've got lots of plans going forward. And that was the penultimate slide, and I'm sorry, slightly late, but that's the end of the presentation. Thank
you. Yeah, thank you very much for your excellent presentation, and I think you've been exactly right in time. It's so. If anyone would like to ask questions, raise your hand or type something in the comments section. And as I can see no raised hands so far, maybe I would start with the first question. And I was just wondering whether whether the philosophy of the staff changed once you've introduced the 5-step method.
I think it's taken quite a long time. I think often staff are so busy, and it's really hard for people to sometimes remember about family members. I know that's a very obvious thing to say, but services have become so much busier over recent time. There's been so much less resource that it seems to me that certain people in services will quite often think about family members and other people might not. And it can be a very personal thing. And I think sometimes it's about whether that member of staff has been an affected family member themselves, so therefore they're more kind of keyed into it. I think where we're fortunate enough to have family workers, I think that kind of I think the kind of family focus permeates a lot better, because we're, you know, people are constantly there, you know, in offices when we were all in offices, you know, kind of visibly there as a family worker in team meetings, talking about families, you know, it's about keeping that profile up. And I think introducing the idea isn't enough. It's about people actually having those conversations with recovery workers day in, day out, for months and years. It's really nice to see we've got a couple of family workers here from Turning Point, and you know, I think the work that family workers do, that's part of it. It's not just offering the family intervention; it's also that kind of whole team focus, which I think is very difficult to get if you don't have those specific people in post and with all their kind of enthusiasm and skills.
Thanks. So, Richard.
Well, hi, Jan.
Hi, Richard.
Fantastic. What a really exceptional and interesting talk. I think that you did everything really proud. And this was one of the best implementation talks that I think I've ever heard. So thank you for that. And nice to see you again after we've been working together for such a long time. I mean, I think that there are a number of things. I mean, the first thing is that one of the messages that comes out from this about implementation is how long implementation takes. I mean, I'm extremely interested in implementation, not only in the 5-step method and other family work, the work I do with other colleagues in India and elsewhere, where we develop interventions which are well researched. We do randomized controlled trials, we show something works. That's useless if it's not implemented. So I'm really interested in how we get that transition from doing research which shows something works into changing practice so that people start to do something in a routine way and an automatic way. And that's incredibly difficult. And I think what you're demonstrating is, you know, we started working together, as you say, 16 years ago. You were inspired to want to continue to develop the family work. You then got a position which enabled you to start to do that. And 11 years on, you're able to say, well, actually, I think we might have started to solve some of the problems. Well, I think that's not that you've done a bad job. It's just how long it takes to embed anything, whether it's motivational interviewing, whether it's progesterone declementi, whether it's CBT ideas. All these things take a huge amount of time, as well as training to implement. The second thing is that one of the things I've observed over the years in implementation is how you've got to have champions. And without champions, things don't get embedded. And the champion has got to be someone who stays in for the long term and actually pushes. And that's obviously what you've been doing. And then what you're now doing is developing another level of champion below you, the family workers, who can then champion within teams. So it's in a sense, in quotes, a typical cascade pyramid model. But to call it typical it minimizes it, but actually, I mean, that's what you need to do as the organization gets bigger and as you actually are successful in developing the implementation. You need other people to also champion, so you need more champions rather than even when it's embedded, as it will get forgotten very quickly. I suppose that the third thing that I thought was you need to write this up. I mean, there's a huge amount of learning there. Which I think, I mean, I've been working with you all these years and I didn't know half the things you talked about. Nobody else knows any of them. So that it needs to be written up. It needs to be in the public domain. Obviously, we now have a recording of this, so I can tell people to listen to 45 minutes and learn about how to implement. But even better if it's written up. So I mean, I know that's another thing to add to the incredibly long to-do list, but maybe you could persuade Lorna that that's something that should go higher up her list, because she writes things for publication more frequently than you do. But so that for the two of you to do it, but with her taking a lead, that would be a really important thing to do, because there's a lot of stuff included here. So thank you very, very much indeed.
Thank you, Richard. That's a really good idea about writing up, actually, and having Laura's skill and expertise would make it feel more possible, I think.
So there's also a raised hand of Ed and of Jill. So I'll hand over to Ed.
Jen, fantastic. And I'm going to agree so much with what Richard, you said. I think the common denominator of making this work, look at all the effort you put in being that champion. And I think what I heard very specifically was when it's embedded in strategy, and if you talked about, what Public Health England, if they not only talk about that very general, support for families, but name specifically what they should be doing. That's included in bids. That's something I took away that is really, really helpful. The other thing that I think in terms of reaching family members earlier, I think that, the digital opportunity to reach families, give them options, has so much potential. And I would be so keen to hear if that does become available nationally. We're a bit away, but we fit within the UK, so that would be unbelievably exciting. I think a question I think I have in terms of mental health and adapting it for crisis, adapting it for personality disorder, because I always believe 5-step would have such a potential, and the crossover between alcohol, substance misuse, and mental health issues is so glaringly obvious. Do you have much opposition from your mental health colleagues to shift their focus away from their clients and include, because the reason I'm thinking is you have the family focus model coming out of, and it always struck me that yes, include family in the discussion. How does that affect you? But unless you have something you could offer families that are really troubled by what they're living with, you're opening up a can of worms you can't support. It sounds like you're creating something that could help that.
Thank you. That's an interesting question. I think we're kind of in early days in terms of talking in mental health services about supporting, well, not supporting family members, because I've been doing that for a long time, but specific ways of supporting family members. And interestingly, so far there seems more of an appetite, and I think it's because so many mental health services see family members anyway, so that people would be bringing their family members into appointments. And I don't know statistically whether it's more common in mental health than it is in substance misuse, but it feels like when you talk to mental health staff, they're already quite in contact with family members, so there's not a big hurdle in terms of moving into a more structured approach. And particularly in crisis services, where particularly for young people, so this one in Leicester is a crisis cafe that young people can drop into, and quite often it's their family members that are bringing them to the cafe, so they're already there, kind of thing. And so it's slightly different dynamic. Obviously it's different in different health services, and for example residential, we've had residential forensic services where people probably haven't seen their family members for a very long time, so that would be a kind of different setup. But I think people are absolutely open. They're kind of open arms. They kind of want something to be able to do with family members in mental health services. I don't think that's going to be such an issue. I think the issue is going to be the staffing model, and I think what we've been able to do, because we've got this service in Nottingham, which it's a pilot already. So it's a 6-month pilot, and we're applying for extension of the pilot. And because because it's a pilot, we've got flexibility. So we're saying, all right, to extend the pilot, let's bring in family work. So it's something that we can do that's not sort of set in stone, and that's easier because it's in a pilot setting. Whereas in a mental health service, it's got its own staffing structure. That staffing structure has been that way for years. It's much more difficult, I think, to then bring in the idea of family work. Yeah, but it's an interesting question.
Okay, that's helpful. Thank you.
Yeah, so Jill.
Hi, Jan.
Hi, Jill.
Hi, thank you very much for that. That was really interesting. I'm very interested in this idea of how you embed things in services. And this, as Richard said, having the champion is crucial, but embedding it in the commissioning structures. But I'm also interested in this, ensuring that staff have fidelity to the model. And we all know what happens. You know, people go off on a training course, they come back, they say they're trained, and then it gets diluted, and that's been well written up in findings, etc. So I'm interested about how, moving forward, staff never have the time, do they? And obviously we've developed the website and we're hoping that that will act as a refresher. But how do you ensure with that massive staff that there is fidelity to the model when they're very, very busy, ensuring that quality and implementation is maintained?
That's an interesting and big question, isn't it? I think what's been interesting over the course of lockdown is that because of doing a lot of online interventions, certainly we have group leads in services. So the group leads supervise people that are doing group facilitation, and they have said it's been a lot easier to sit in on groups because they've been online. So I think there's capacity for more kind of observation and sort of, because supervision is okay, but whatever people bring to supervision is what they bring, you know what I mean? Whereas actually observation is something completely different. And I think we're going to have more capacity to be able to do not observation in the sense of sort of, judging observation, but kind of constructive observation. Because of the online, I think it's got a different dynamic. So we're doing more group observation, interestingly, in online groups than we ever did in face-to-face groups, because not only logistically it's harder for the observer to get to the place, but also because it's slightly less intrusive, because lots of people in groups don't necessarily have the camera on. The person can be there and actually not have to sit in a group of people and observe, and it can all be a bit weird. I think online it can be a lot more helpful. So group observation, I think, is one thing. And I suppose, as much supervision as possible. We've only, as I say, in terms of accreditation, the difficulty with the accreditation process is that people become accredited and then move on, which is, it's always the way, isn't it? In substance use services, people go from one provider to the other, to another. And I'm hopeful that the Family Worker Forum will enable us to do some CPD as a group of family workers. So being able to, at the moment, the forum is in the stage of, what are we all doing? How do we show good practice? How can we not reinvent the wheel? How can we make sure that we're kind of doing something a bit consistent in terms of assessment, etc. But I'm hoping that once we've done that and we've got the kind of basics, we can move on to, right, okay, let's do some CPD now. Let's have a look at some of the new 5-step materials that you've been developing, which look really interesting. Let's do some of that together now that so I'm hoping that the forum, will give us a chance to be able to do some of that.
Good. I think that's really interesting, because there's obviously gold standard accreditation. Everybody thinks it's wonderful, etc. But it's incredibly time consuming. So we have to adapt, don't we? And maybe, as you say, that thing of people being used to being observed and getting feedback, that it comes embedded and you do some spot checks for quality that are constructive and people find helpful. So I think there's some, interesting ideas there. So thanks very much.
So Richard raised his hand again.
I'm sorry. Yeah. Well, the last two questioners both raised things that I wanted to come back on. Just to do to take some of the answers that you were giving to Jill. Then, I think the interesting thing about observation, supervision through observation, as opposed to supervision through hearing what people remember about sessions, is actually, it's very similar to what is done in the 5-step method accreditation system, which is that you have recordings, and people don't hear what people think they did. They actually listen to what people actually did, and the important, I think, one of the most important things about the accreditation system is not having your work accredited. It's actually the self-accreditation bit. It's people listening to themselves against criteria and thinking, actually, in the privacy of my own home, how well did I do that? Could I have done it better? What did I miss out? Now, that idea, using whether or not people go for full accreditation is almost immaterial, but the idea of using it as a CPD method, that people actually listen to their recordings of their own groups, and rate themselves and think, what did I do that was good? What did I do that I could have done better? That can be an amazingly powerful CPD piece of work, which obviously is still time consuming, but doesn't have any financial issues other than people's time, and can be, in a sense, less threatening than putting yourself up because you're doing it to yourself. So that was one thing I was thinking of. In terms of the conversation we're having with Ed about mental health, I suppose I thought about two things about that. One is that although people are very aware of the importance of family members, because family members are often coming with the person with the problem, the mental health services have in the past suffered from the same prejudices that many other services in substance misuse and so on have as well, of being very blaming of family members, and sometimes even more in mental health than in substance misuse. The number of times where I've heard people in services say, well, no wonder he or she turned out like that. Have you met the parents? So, I mean, this whole thing about seeing that. So although I suppose it's, if that's not coming through, then that's really great. But that change of attitude is something that I suppose one's looking for in all services, so that people see family members not only as needing help in their own right, but also as people who can be partners in the journey that people are going on to come through either substance misuse problems or mental health problems or intellectual disability problems or whatever. The other thing, of course, is that you started off when you were talking about the 5-step method about it being evidence-based, and of course the issue we have with transferring it to other areas other than substance misuse is that the evidence base that it was created from and the evidence base that we have for its effectiveness is all related around substance misuse. So I suppose I'm very pro the idea, because it's always struck me that it's a very generalizable model, but you'll not be surprised that I'm going to say that I think it's important that you collect some data and evidence about this, so that we can say that using, say, the stress strain coping support model is in other areas is also evidence based.
Yeah, absolutely. Yeah, thanks.
Yeah, so wonderful. Are there any further questions? Just raise your hand or write down something in the chat.
Oh, Mina's got a hand up.
Oh, okay. Mina? Yeah.
Yes, just
Hi.
thank you, hey, very much. Very, very interesting and something to learn for Finland for sure. Coming from Finland and working with children of affected family members, do you have specific groups for children, and both for young and adult children for affected family members?
That is an interesting question. We did. So we were fortunate to have Ed and Lorna come over a few years ago and train some of the young people's team staff in steps to cope. And I think, I mean, it kind of took off in some areas, but I don't think we put as much into the implementation, or we didn't have the resource to put as much into the implementation as we did in the adult sphere. Is that better? Yeah. Okay.
Yes, you're not repeating that.
So we sort of had a training event and with young people's teams, and we tried to sort of get steps to cope up and running, mainly on an individual basis with young people affected by parental substance use. I think looking back at that, we probably didn't have a concerted enough approach to the implementation across different services. And we were thinking about we were talking about trying to relaunch some of that. I think what's happened for us is that only certain services have young people's teams attached to them. Quite often, young people's teams services are commissioned separately. So quite often we're working with an adult service, but the young people service is provided by a different provider. So where that's the case, we tend to do less affected, young people affected by other substance use work. However, I think now it is becoming more common for services to have both an adult and a young person
aspect together in the same service. And that's why I think we need to revisit the idea of working with Steps to Cope, because it's something that certainly young people's teams often will say, you know, what do we need to do? How can we work with people? So yeah, I think we haven't, and I don't think we've implemented it as well as we could have, but I'm hoping that we could in the future, because there's certainly a massive need. I think the other problem for us is that people fall through the gaps in terms of young people. So if they're not using substances themselves, they're young people not using substances but affected by parental substance use, it's almost as if they don't fit in any of our commissioning structures. So they're not in a young people's team as in young people using substances. Their parents may be in substance use services, but so the young people themselves who are affected don't fit anywhere in terms of commissioning. And that's a real difficulty. So there's almost like a kind of grey area a little bit about which service works with young people affected by other substance use. I think it's really patchy in England in terms of how that works. There's some brilliant local organisations, but it's very random in terms of, it just depends, it's kind of postcode, I think, postcode lottery, in terms of whether you've got a really good local grassroots service who does that or not. I'm not sure how much that answers your question, Mina. I think
yes,
we're not
certainly
not as far along with it as we are with adult work.
Yeah, it's the case in Finland too. We don't reach out to young people through the substance abuse services, but via internet, like the Steps to Cope website works. Yeah. Interesting. Thank you very much.
Okay, thanks.
There has also been another question in the chat about the maximum size of the groups with consideration to step 1 and allocated time for this. Could you briefly outline this?
Yeah, I wonder whether, I'm just noticing, sort of, Bex, you're on the call. Would you mind saying a little bit about, I mean, you've actually been facilitating 5-step groups in Somerset, and we're just wondering what you've found in terms of group size online and whether it's different to face-to-face. Is that okay?
Yes, that's fine. I'm not that great at this sort of thing. Thanks, Jan. Yeah, so what have I found? I've done group 5-step where we've had probably about 8 people in a room. This is face-to-face kind of thing. It is quite hefty, that first session, and it can be quite emotional for people. And so sort of, you know, holding that in a group can be challenging, but it actually worked really well. What we found online is it took us a few, you know, with COVID, it took us a few couple of months before we actually got the virtual group going, the 5-step, and we've only actually held, I think, 2 actual 5-step, you know, over 5 weeks kind of thing, and we had about 4 in each one, which was ideal. There's enough time to sort of spend with each person looking at the impact individually. So yeah, but I mean, our area service, Somerset area service guideline for groups is about 12 people, I think 12, 15, 12.
Yeah.
So that's quite, you know, that's quite a large number of people. We do each session for about 2 hours when we're doing it as a group. So yeah, we'll see. It's you know, it's developing really, doing it as a big group. I have done it, but before the family work was actually commissioned to be a main part of the Somerset service, I was one of those recovery workers who did the family work as a add-on, and you know, I was very sort of passionate about it, but squeezing it in, it was like, you know, something you had to beg almost for a bit of time and space to be able to do it. And we ran a really successful 5-step group then, where we did there was about 8 in that group, and it was just such a in a way, was it Jill who said, you know, sticking with the authentic 5 steps, sort of not by the book necessarily, but really, I'm not sure that we did do that completely and utterly, but what I do know is that the group worked really, really well and covered all of the parts of 5 steps over the 5 sessions, 6 sessions. Every bit was implemented, but actually it wasn't kind of like each session one at a time. So it's yeah, there's sort of work to be done around trying to perhaps keep it completely authentic and stuff. So lot of learning going on. But I think for the people, you know, who came to have that support, they got a lot from it, and that's, to me, that's what measures whether or not I'm delivering something that is supportive to those people. That's actually all I really care about. Really, is if I get a feedback form that says I've walked away feeling a little bit lighter and that I've connected with a few people, and that I am coping a little better or know where to go when I need to find some support to cope, then that's 5-step, isn't it?
Thanks.
So yeah.
Thanks.
Okay.
My sense, yeah, I think, yeah, my sense is that I think that generally what we find in other groups also is that group size tends to be smaller online. I think because the thing about the online group is also you get the whole camera issue about, you know, you can't make people have their cameras on. You try and get people to have their cameras on for check-in and check-out. Not everybody wants the camera on, not everybody feels confident enough to talk in a group. So there's that whole issue that you don't get in face-to-face groups. But my sense is that we've had smaller groups online and that kind of works better. I would imagine it would be really hard to do an online group with, you know, 10 people for any of the steps, really. So I guess most of our online groups have been maximum about 6 to 8 people, I think.
There's also another question by Ed about using the family handbook through the contact point. Do you get any feedback on how useful this is for clients?
That's an interesting question, and we don't really, because often they're people, they're kind of, it's almost like a brief intervention, like an opportunistic intervention where the family member's phoning in saying, I'm really desperate about my loved one. Can you get them into treatment? And it's an opportunity to say, well, you know, give them information about the treatment service and how that person can refer themselves, etc. But also, you know, have you considered any sort of help in your own right? And we don't. We just, the handbook's kind of go off, and that's that really, unless somebody then refers himself into their local service for family support. But then even that, we probably wouldn't make the link. Yeah.
Okay, so are there any further questions or comments? I mean, we're almost approaching 1.5 hours, so so I would say thank you very much for your excellent talk and for your excellent work, and I absolutely I'm looking forward to hear also about your experiences when you transform the 5-step work to other areas. But I completely agree with Richard that it's very useful if you also have a look on how to evaluate this. But I think it's really really a lot of expertise you have developed during all these years, and I'd really would like to congratulate you for that. So thank you very much, and I would also like to announce that one issue we were discussing today has been the need of reaching family members earlier, faster, better, and this will be the topic of our next webinar on the 22nd of June, held by Ed Zippler. You can find all the information on the AFINet website. And I also would like to announce that on 9th and 10th of September, we will have a brief 2 half-day conference where you still can, well, submit any abstracts on topics you feel relevant, and we will use this as an opportunity also to give AFINet members some space for presenting their work. And we truly regret that it hasn't been possible to have a face-to-face conference this year, but we are planning to have one next year in the Netherlands. So again, all of you who are not yet members, you're strongly encouraged to become one. And thank you all very much. And so have a wonderful afternoon, and I'd be happy to see you again on the next webinars and in the future.
Thanks all. Good to see you.